Thanks a lot for the opportunity to present this. What I'm going to present is based on the outcome or the contribution of many participants at a workshop that took place in September around discounting. So let's start just by considering a project that has some health benefits and healthcare costs and what we need to know to make decisions. Well, we imagine that the origin of this slide represents what's currently available, and we've assessed the evidence, and our new project that we're considering, we expect will avert 100,000 DALYs, but it will cost some $30 million. We can summarise that project as offering us at one DALY averted for every £300 we spend. Is it worthwhile? Is it a good project? Well, that kind of depends on where that $30 million has got to come from. If it's got to come from existing commitments, then the question is what else could have been achieved with those resources. If that's going to be new money, then again the question is, well, what else could we have done with that money elsewhere? So we need to have some understanding of health opportunity costs, or if you like, the marginal productivity of our healthcare system. What else we could do with those resources? Imagine that our assessment is that this healthcare system that is about $400 spend averts one DALY. What does that mean for this project? What it means is that the benefits of 100,000 DALYs averted exceed the health opportunity costs, because that $30 million could have averted 75,000 DALYs elsewhere. This project's good value. The net health benefit is positive. What else does it mean? Well, it means that the healthcare system would have had to spend $40 million in order to generate similar benefits elsewhere. So again, we can express the value of this project in terms of the difference between how much we'd have to spend to generate those benefits and how much the project costs. What happens in a different healthcare system, maybe one that spends a little less on healthcare, where health opportunity costs are greater, where marginal productivity is higher. Let's imagine a healthcare system where we expect that $100 spent on healthcare gets to avert a DALY elsewhere. How does the project look there? Well, now it doesn't look quite so good. That $30 million could have been used, error on the slide, could have been used to avert 300,000 DALYs elsewhere. So the health opportunity cost exceed the health benefits of this project. And equally, we can represent that in terms of healthcare resources as well. It's the equivalent, if you like, of a loss of healthcare resources. So what does this mean when we think about these effects over time? What it means is a simple project with health benefits and healthcare costs. We have a time stream of health benefits over time in column 2, and a health stream and a time stream of healthcare costs in column 2. How can we make those commensurate? Well, actually, those additional healthcare costs are, in fact, health opportunity costs, health that could have been gained elsewhere. So we can convert those healthcare costs into a stream of health costs, with knowledge of the health opportunity costs in each time period, those KHs. We can also express that time stream of health benefits and health costs in resource terms, healthcare resource terms, simply by rescaling health benefits into healthcare costs. What healthcare resources would have been required to deliver those benefits in each time period? And of course, we can express those time streams, the time stream of health effects, health benefits, health costs, as time streams of equivalent consumption effects, if we have some information about the equivalent consumption value of health gained and health lost, columns 8 and columns 9. So we start to see the kind of key parameters that we need to be able to estimate to think about these time streams of effects. How should they be discounted? Well, depends what our focus is. If our focus is on health, then we need to discount at a rate that's relevant to health. We might found that on the rate, on the opportunity cost that the government faces in financing the healthcare system, in other words, RS, the rate at which government borrow, and some revealed indication of how in their budget allocation, their allocation of expenditure over time, they value future compared to current health. In other words, the growth in this this health opportunity cost. If we express things in terms of healthcare resources, we simply need to discount at the opportunity cost of financing healthcare, RS. If we want to convert everything into consumption, then we need an appropriate discount rate for consumption effects. And that we can appeal to the Ramsey formula, where delta represents the, if you like, pure time preference, and eta GC represents the wealth effect, which we'll come back to in a little while. Of course, most projects don't just have effects on health and healthcare costs, but they have other effects as well outside the healthcare system on private consumption. Imagine the same project. It costs $30 million. It offers health benefits of $100,000 averted, but it also offers consumption benefits of $40 million elsewhere to the economy. This sounds, on the face of it, this sounds great. It costs $30 million, but we get $40 million back, and we get some health as well. But it's not that good value once we start to consider the opportunity costs in two respects. First of all, in this healthcare system, if we think that health opportunity cost, if you like, the marginal productivity of healthcare expenditure is about $200 a daily, in actual fact, that 30 million means that there's $150,000 we could have averted. So we have a net loss of health outcome, 50,000 additional dollars which we could have averted. And we don't gain the 40 million, because it kind of depends on, well, what would have been the consumption effects in the wider economy of those health opportunity costs. So we need to have some understanding of, if you like, how many healthcare system dollars required to generate one consumption dollar elsewhere in the rest of the economy. Imagine that's kind of one-to-one. Then we would expect consumption opportunity costs of about 30 million. So what this project actually offers us is, in net terms, a net loss in health, but in return, a small net gain in consumption value of 10 million. Is it worthwhile? Well, that kind of really depends on how much we think health outcome is worth. So in this case, the project's only worthwhile if we think the consumption value of health is somewhat less than $200 per daily. Let's just have a think about how all this pans out when we think about time streams of these effects. Well, it's the same. The columns 2 and 3 are the same as before. We have a time stream of health benefits from the project, a time stream of healthcare costs from the project, but now we also have a time stream of consumption costs. Of course, if they're benefits, then the sign's negative. The way to think about these different effects, these time streams of different effects, is to think about two time streams going on here. The first is the time stream of the effect on health, which is combining the health benefits with the opportunity costs of that time stream of healthcare costs in column 3. So column 5, we have the project offers a time stream of net health benefits, but it also offers a time stream of net consumption costs, which if negative sign a benefit. So we need to be able to estimate these two time streams associated with projects, and for that we need to understand health opportunity costs, but we also need to understand that term, KC, which is, if you like, the consumption opportunity costs of healthcare expenditure. Once we've estimated those two time streams, what should we do with them? Well, we can make them commensurate by converting them into their equivalent consumption effects. Convert both into a time stream of consumption effect simply by multiplying the health effects by what we know about the consumption value of health, those net health effects. And we need to know something about not only the, if you like, consumption value of health, but how that's going to evolve over time. Of course, consumption is only one of potentially 3 common numerators we could use. We could equivalently convert everything into a time stream of equivalent health effects or into a time stream of equivalent healthcare resources. The advantage of converting everything into a time stream of equivalent consumption effects is that we can then discount those equivalent consumption effects at a rate appropriate for consumption. In other words, social time preference from appealing to the welfare arguments of the Ramsey formula. How might we, of course, projects are going to have effects not just in one country or jurisdiction which have got a certain set of estimated parameters, the Ks, the Vs, as well as the directly estimated effects of the project itself on health, healthcare costs and consumption, we're often going to have projects that are going to have effects on many different countries and jurisdictions. How should we deal with that? Well, what we need to be able to do is to think about those effects in each country where these key parameters will differ. You'll notice that all the key parameters have country subscripts. So we need to estimate these effects in each of these countries' jurisdictions, those time streams, convert each of those time streams of health and healthcare costs and consumption into a time stream of consumption within each of those countries, and then discount back. And where we sum is in summing those net country-specific net present values in the bottom row. So I'm sorry this is quick, and I'm going to just try and summarise our kind of thoughts on possible default estimates for these key quantities. First of all, health opportunity cost of healthcare expenditure. We need to understand that. It will be country-specific, and we need to understand something about its evolution over time. We do have initial estimates based on cross-country estimates. We do have some initial projections based on published projections of healthcare expenditure and consumption growth. Of course, those need to be updated and improved and ideally founded on within-country data where that's available. What about the consumption opportunity costs of healthcare expenditure? Well, formally and explicitly, relatively little is known about that. We do have estimates in the UK for precisely that. A reasonable or a default assumption might be a one-for-one, that $1 spent on healthcare delivers $1 in net production or consumption in the wider economy. A default assumption that the real value of these effects grows with growth rate of consumption probably wouldn't be unreasonable. Can we do better? Yes, we can. There's lots of evidence out there that could be marshalled to try and estimate these effects. What about the consumption value of health and its evolution over time? Well, in many respects, this is the subject of other methods papers in the reference case. I think it'd be a great advantage to think about the evolution of the value, the consumption value of health, to found that on estimates of the expected growth in consumption opportunities, which is embedded as part of social time preference. We can do that by having default assumptions about income elasticity of demand for health. A reasonable but conservative estimate would probably be 1 for income elasticity, so that the consumption value of health would grow at the same rate as consumption. Of course, alternative scenarios could be developed that are country specific. What about other sectors? Health is not the only publicly constrained sector with particular opportunity costs. There are many other constrained sectors where opportunity cost or their shadow price is important, where we don't have estimates, direct estimates to work with. One way to think about this is to take what we know about the health sector, in other words, the ratio of the VH to KH, as an indication of the shadow price of healthcare expenditure, and apply that to other sectors. That's something that we've been doing in the UK for public health projects. It might be quite reasonable because you would expect government to try and equalise these shadow prices across the different categories of constrained public expenditure. What about time preference for consumption? I think there are good normative reasons why we should set aside pure time preference for social choices. That's something that can be argued about, but even if we don't, it'll be relatively small. We need some idea of what ETA might be, and it's best thought of as inequality aversion when it comes to social choices. A reasonable start point would be ETA equals 1. That would be quite conservative given what we know from high-income countries. And of course, it's also going to depend on our expectations about consumption growth in the future. But those can be founded on reported measures of growth in national income, those kind of projections that are routinely reported. We can have alternative scenarios where we have more information about whether ETA might differ in particular. And we can update that as evidence and values specific to low and middle income countries evolve. We can also start to think about whether we might found this on estimates of growth in median income. Catastrophic risk, which is often included as part of the discount rate, I think it's quite useful to think of catastrophic risk as being true catastrophe in the sense that there is no possibility of rescue of any private or public sector projects, and all costs and benefits fall to zero. Effectively, that is a very extreme event of the end of, essentially the end of the world. There's no possibility of rescue. There have been some attempts to elicit those kind of probabilities. They're pretty low, despite the uncertain times we live in. I mean, I think there's a reasonable case just to set aside those kind of truly catastrophic risks. Obviously, there's other catastrophes that are catastrophes, but for which recovery is possible. The effects of those are likely to differ across projects, so it'd be inappropriate to try and embed that in a common discount rate for consumption of effects applied to all projects. I think I would argue certainly that project-specific risks should, as far as possible, be included in the analysis of how we get to consumption-equivalent time streams of the effects of the projects, rather than being embedded in some common discount rate or project-specific risk premium. What about macroeconomic risk? This is effectively trying to adjust for the fact that we are increasingly uncertain about future consumption, and that increasing uncertainty has a, if you like, non-linear effect through the discount rate on our assessment of the net present value in future periods. Basically, we need to have a decline in our discount rate applied to just account for the non-linear effects of this increasing uncertainty. What we tend to see is that for time horizons less than 4 years, that effect is quite modest, and we could decide to just set all that aside for projects with time horizons shorter than 40 years. However, for time horizons that are longer, or where we think macro risk, uncertainty in consumption, is extremely large and growing rapidly, then we might want to account for it. But if we did, it should reflect those non-linear effects rather than the kind of behavioural evidence. And I would suggest that we would want to do that for projects with betas of zero. I'll come to what betas are on the next bullet. I think one thing that came out of the workshop, which I thought was really interesting and really quite important, although underdeveloped in this area, is the interaction of project-specific and macroeconomic risks. That actually be really useful to have some qualitative indication of whether or not projects are likely to be strongly pro or counter-cyclical. Because those that are counter-cyclical are more valuable because of that compared to those that are pro-cyclical. And I think there's a lot of work that could be done to think about how we might make those assessments more quantitative, following the kind of lead and insights that we have from corporate finance. I want to try and sum up quickly because I'm pressing. I think in terms of future research, on health opportunity cost, there's a lot of work that's been done, but there's a lot more that needs to be done, and that's true whether it's for discounting or not. I think we can continue to refine those estimates, but of course bespoke estimates based on within-country data would be really important, not just for this, but for decisions within those countries as well. I think consumption opportunity costs to healthcare expenditures, an awful lot that could be very quickly done, marshalling existing micro and macro evidence to establish what we know about the link between changes in health and net production and consumption in particular economies. What about the consumption value of health and its evolution over time? Again, I think that's really the subject of other methods papers and the endeavour there to try and get estimates bespoke to low and middle income countries. I think when we think about other constrained sectors, I think it would be kind of nice to think that we can estimate shadow prices for those, but I think that's a much more longer term goal. I think in the meantime, using what we know from the health sector, where we know quite a lot compared to elsewhere, would be a reasonable start point. What about time preference? Well, I think we know a lot. We know a lot in principle, but I think it would be good to review theory and evidence in a bit more detail about how ETA might differ in lower income settings. I think there's certainly something to be said for starting to consider growth in median income as a foundation for social time. Catastrophic risk, I don't think project-specific risk, I think we've got a set of methods that are very useful in making sure we account for those things in our estimates of equivalent consumption. macroeconomic risk and prudential savings, I think there's a real case for producing some pretty usable tools which allow us to account for macro risk, the uncertainty in future consumption growth, that are relevant to the kind of projections that we have for low and middle income countries. And then the interaction of project-specific and macroeconomic risk. I think there's a real job of work to be done here, a real rich seam to exploit some of the insights that we get from corporate finance, but to apply them to these kind of social projects, where actually this interaction of project-specific and macro risk might be extremely important, where that macro risk is high, and where those projects may well have quite a big pro or counter-cyclical effect. Okay, I'm going to leave it there, and I'm sorry if I've overrun on time. I can't hear anything, by the way.
I hope you can hear me. Say thank you. We're going now to hear from our two discussants. The first discussant is Miqdad Asaria, and he will speak, and I will give the mic over.
Thank you. So I'm working on an IDSI grant in India where we're setting up a HCA agency in the government. So that's kind of my take on Karl's presentation, is interpreting this in the Indian context. I'm also a research fellow at the Center for Health Economics at the University of York. So very kind of briefly, what I got from Karl's paper is that just because things vary over time, it doesn't mean you have to discount them. A lot of these things you can just model. So you can model things like changes in consumption values, changes in opportunity costs, all these kind of other things, catastrophic risk, other kinds of risks can be modeled in. And the things that so the model should kind of project all of these things out, convert to some kind of a common numerator, and then that common numerator, in this case, consumption value, is what should be discounted. So that's what the discounting focuses on. So I think in terms of Karl's paper, I think it's methodologically sound, it's elegant, it's nice, it's a nice theoretical piece of work that all seems to add up, at least as far as I could see. So I want to say a little bit about how I started thinking about being able to apply this in India. So the government expenditure in India. So I should first of all say that when you read the paper, it's very clear that Karl's epistemic zero point is the UK NHS and health. And he starts from there, and then his kind of point of departure is from that, and from QALYs, and from government spending, and from universal health coverage, and all of these things which India doesn't have. So then suddenly you start thinking, oh, that's really nice in the model, but is this going to work? And so one of the things is that government health expenditure, or government expenditure in general in India, is typically focused on those who are below the poverty line. And that means below something like 50 cents a day, which is about 30% of the population, which is 360 million people, so about as many people as native English speakers in the world. And when the government provides healthcare, they provide inpatient hospital care. That's what they cover. And when you provide inpatient hospital care, you often result in people having to pay further costs, right? So they have to pay these outpatient costs, they have to pay diagnostic costs, they have to pay medicine costs, other things. And so often there's this out-of-pocket expenditure that goes along with this inpatient care for these very, very poor people. Right? The other thing is India has 29 states. So the UK is this tiny little, very homogeneous country. India has 29 states. Each state has its own budget. The government also have budgets. Each state has a very different GDP. So, it ranges from $7,000 to $900. Demographics are different. Mortality rates are different. Disease prevalence. It's basically lots of different countries. And within each of these states, there's lots of different populations. So can we apply Karl's formulas, right? So this is Karl's formula. So imagine you do these things. Now, these formulas are less complicated. They look less complicated here, but actually you got a time stream of things, right? So you're going to do this for 60 years. Each one of these things would be repeated 60 times potentially, right? And then you do this across 29 states, and then you try and find the parameters. Now, maybe you could do that. Every parameter is likely to vary by state. Those who benefit from these policies are pretty much completely distinct from those who would pay for them. So actually, maybe you need two versions of each of these parameters to start valuing the costs and valuing the benefits. And then if you start putting explicit kind of values of health on different people in different states, I mean, you can probably have some kind of clever academic semantics to say it differently, but I think states will figure this out very quickly, and it's not going to be politically tenable, right? They're not going to accept this, to say that somebody in Bihar is worth, 1/100th of somebody in Kerala. That's just not going to fly. And then the other thing is, in India, we don't have one payer, so we've got lots of payers. So these opportunity costs are complex mixes of things which evolve differently over time. Karl's nice model is just about health and consumption, but as soon as you start putting other sectors in, you get lots more of those Ks and cross-elasticities, cross-opportunity costs. We need to make sure that these changes in out-of-pocket expenditure that happen due to health spending are somehow captured as well, so that can lead to impoverishment and other health costs in themselves. So we've got lots and lots of parameters to estimate and very limited data. So in conclusion, I think Karl has a very elegant theoretical model. He comes at this very differently to a lot of other people because he's coming at it from a kind of UK NHS perspective. And I think the big strength of that is he's really thought about how to value costs. And I think a lot of this literature doesn't understand how to value costs very well, or doesn't explain it very well, or doesn't communicate it very well. And I think often policymakers get very confused by it. And they think, if something costs this much to the government and this much to somebody out of their pocket, why can't you just add those two dollar values together? And so I think Karl spends a lot of time talking about why that you can't always just add those $2 values together. And I think that's a really useful contribution. I think a real world application with multiple sectors in a country without UHC, with multiple different payers, is going to be challenging. Karl suggested some default parameters, so maybe that helps. It'd be interesting to really work this through a case study and see how far you can get with what he's proposed. So the other thing I want to say is that none of these challenges are specific to discounting. Actually, this is just Karl's take on benefit cost analysis. And he's presented it really clearly, and he's highlighted all of these parameters. And actually, none of what I said is a critique of the discounting part of this or the challenge. And actually, Karl does a really good job of saying why you don't need to put all of these other things in discounting, but he doesn't say an awful lot in the paper about the discounting bit and what you should really do with the discounting part. I'm going to stop there.
Thank you. So our second discussant is Gernot Wagner. Thank you.
Thank you, Maureen, and thank you, Miqdad. So after some very specific look at how one might actually do this, a step back and a somewhat higher level look at what are we talking about here? Four parts to Karl's paper, 4 points I'd like to make. So one is sort of this fundamental question, is it okay to discount future health? Do we have enough evidence to actually do it? What's missing? And what to do? So is it okay to discount future health? Well, economists have this standard diminishing marginal returns argument. Health turns out different from other goods, and the low middle income country context itself might pose some fundamental challenges to some of these standard assumptions. So at the end of the day, yes, this argument, as an economist, I would have to say that yes, of course, we are in this world. That said, no, that doesn't really hold water when one looks more deeply as the fundamental justification, especially when one looks at the sort of more philosophical, ethical underpinnings here. Now, fortunately, there are some fundamental reasons that even ethicists would subscribe to, philosophers would subscribe to. There are large risks and uncertainties in health investments that by itself calls for discounting. And there are what at least Professor Greaves, Oxford, in Discounting Future Health, a philosopher herself, calls instrumental benefits of earlier health improvements. So this, what in economic terms one might call something akin to the relationship to productivity gains, some sort of notion of healthier people are more productive, macroeconomy is doing better as a result, and so on and so forth, which of course is very much, again, a reductionist economist's argument on top of the philosophical one. But those two, to me at least, strike me as the fundamental ethical, philosophical, and of course also economic justifications for discounting future health. Now, what does that give us, right? What does that mean once we dive into risk uncertainty on the one hand and this instrumental benefits argument on the other? Now, quickly before then, let me just look at this very quickly, and I don't need to add much more than Miqdad already did. Yes, there is that. Now, that does not mean that we shouldn't. On the other hand, good luck. Okay, so what's missing in all of this? Back to the risk uncertainty bit and sort of this productivity gains notion of how do we look at the relationship of investments in health projects, health outcomes, and the economy, macroeconomic factors. Well, the first bit is this risk and uncertainty business, right? So one of the original justifications for discounting in the first place, yes, that should matter too, right? So let's take it seriously in our actual analysis of calculating the discount rate. And Karl spent quite a bit of time on this in his presentation. In some sense, not quite as much in the paper itself, but yes, there is this non-zero probability of health interventions preventing these low probability, high impact events. And it's not sort of the asteroid striking, everything gets wiped out. No, it's sort of pandemic, wiping out 10, 15% of the population. That, to me at least, seems serious enough to take into account. And yes, there are non-zero probabilities, and yes, investments in vaccinations on the one hand, or whatever else that might prevent a catastrophic outcome like this. Of course, all of that matters when we then look at the relationship of discounting in this context of highly risky, highly uncertain investments. And yes, there is this. There is the fat tails business, right? We can't exclude them fully. And unfortunately, for us sort of standard benefit cost analysis, expected value, sort of that kind of framework that we're used to as economists, they may well dwarf everything else. Sort of definitionally, if it is truly a fat tail, we are no longer allowed to actually take the expected value, or it would explode. It would be infinitely much. Right? So if we take that truly seriously and to the statistical extreme, then yes, we have this extreme outcome that the extreme event, however low probability it has, right, 0.00001 times infinity is still infinity, turns out. So if we take that argument seriously, well, it puts the burden of proof, at the very least, at the opposite extreme. That, of course, matters, right? Risk and uncertainty itself might dwarf everything else. And then Karl addresses as well in his presentation, there is in fact a factor that we basically completely ignore in any of these calculations. Financial economists call it beta. Climate economists by now have their climate beta. There ought to be something akin to this health beta, the relationship of investments in health projects with how the economy is doing. Karl mentioned the phrase cyclical versus countercyclical. Well, that by itself may well, the answer to that question is sort of categorizing simply two categories. Do things have beta greater than 1 or a beta less than 1 or less than 0? Simply putting things into categories alone may make a huge difference. Just to give you a quick sense, there's a long history of this in climate economics. Gernot wrote a whole book about it. One graph that jumps out, not from the book turns out, but from a paper that feeds into some of this discussion. we have the discount rate here on the y-axis, our row, and we are looking at the effect of beta on that discount rate. Standard assumption is beta is equal to 1. That's the base case that very, very few people question. Well, the greater beta, the greater the discount rate, the less value the investment in that project. And it turns out it doesn't take much for the discount rate to decrease dramatically, and maybe even in arguably extreme cases, but not that extreme cases, you have negative discount rates, solely as a result of the relationship between the investment in a particular project and its correlation with macroeconomic. With productivity is one link, healthier people are more productive, and vice versa, then that is clearly something that ought to be taken into account. And frankly, once again, that may well dwarf everything else we do when it comes to parameterizing some of these other equations. So what gives? Well, yes, we are justified to discount. Do we have enough evidence? Let me just leave that here as a question mark. What's missing? The extremes. And at the end of the day, if there is one thing that we ought to be worried about that may well decide everything about even positive versus negative discount rates. Let's forget about 1% versus 2% versus 3%. Is it a positive versus a negative discount rate? Which makes a huge difference. The beta, the climate beta, sorry, climate. Somebody speaking. The health beta in this case, the LMCI health beta, if you will, is maybe the most crucial parameter of the model. Thank you.
So, Karl, I hope you can hear me, and I will just ask you if you have any reactions to the discussants' comments. I'm asking the discussants to join at the front of the room now, and if you'd like to react to their comments, that would be great, and then we'll open the floor to questions.
Yeah, thank you. Can you hear me?
Yes.
Can you? Okay, great. Thanks. I'll be brief. Thanks to both for the comments. Miqdad's absolutely right. I do have an epistemic starting point, as we all do, and none of us can escape it. And he's right. My epistemic start point is the UK and the NHS, and the experiences of being involved in policy and trying to inform policy and the way in which to try and communicate to difficult things and controversial things to people who have to bear the political responsibility of making those really hard and difficult choices. So he's absolutely right. That is the epistemic start point. But I kind of reject the notion that I've kind of made the world complicated. You know, don't shoot the messenger. The world is complicated, and that ain't my fault. And I haven't made it any more or less complicated. All I've tried to do is to abstract a little from it, and in the paper say, okay, let's think. We know the world's really complicated, but let's just boil it down to two to three things that can happen: healthcare costs, and consumption, and kind of work through what you would do in that simple, rarefied world, and see that trying to embed, even in that simple world, trying to embed everything in discount rates for particular projects is pretty hopeless, and it hides a lot of stuff that really ought to be made explicit so it can be open to scrutiny and accountable deliberation. So I would argue that I haven't made the world complicated. Can this be applied to a much more complicated world? Well, yeah, I think at least being clear about the fact that we want to identify the streams of effect, value them appropriately, and then discount is a helpful start point. So, for example, the slide which has got the three different countries, A, B, and C, they don't have to be countries. They can be jurisdictions within a country, states, for example. They could also represent different populations. So the poor who are eligible for publicly funded healthcare versus those that are not. So I think the principle of trying to work through the complexity that is the reality not just of the Indian healthcare system, but most healthcare systems, including the complexities in the UK, to be perfectly frank, is kind of a good start point. So I won't go on any more about that. Gernot's points. I think Gernot was saying that we should discount health, and I agree. The logic, it's not so much an ethical issue, it's just the kind of logic. The first question I've got is, do you think you can transform health gain, health losses into their equivalent consumption effect over time? If the answer to that is yes, which it kind of has to be if we're in a room considering benefit cost analysis, if the answer to that is yes, then of course we can discount those streams of consumption, which is logically equivalent to discounting the health effects. Not at the same rate as consumption, because we've adjusted those streams of health for their consumption value. So we kind of have to do, and I think there's a real value in casting it in terms of consumption, because then really discounting turns on two things. What do you think the prospects are for future economic growth? And secondly, how averse are you to inequality? The more averse you are to inequality, the higher your discount rate if you think we are going to see economic growth. Finally, I'll just finish on this. I think Gernot's quite right. I do think there's enormous value. Oh, just one thing. Absolutely, there are catastrophic events which are not like an asteroid hitting the Earth, that are recoverable. I guess my point was that those are important. Indeed, they're important, and because they're important, they should be included explicitly in our evaluation of the effects of the project over time, and not embedded in a common discount rate, because the effects of projects and the effects of catastrophe on projects will differ across projects. And then finally, I totally agree. I think there is huge value in being able to better understand the betas for these kind of social projects. And I totally agree. Simply being able to classify projects into, you know what, this is beta less than 1, this is beta less than 0, this is beta greater than 0, would be hugely beneficial. And then the next step being, actually, let's integrate that with what we know about macro risk. I think there could be huge value there that's currently unexploited. Thanks. I'll shut up now. I've been talking too long.
Thank you very much, Karl. So, are there any questions from the audience? Are there absolutely no questions from the audience? Well,
yeah, I don't think that's good.
So Miqdad, Miqdad is going to rescue us by asking a question. And if once he's asked the question, I suppose I will ask you to. Yes, Miqdad.
Hey, Reid. I can't hear Miqdad, I'm afraid.
Can you hear now? No?
Yeah, I can. Yeah.
Okay. So this is with respect to the fact that you have developed your methodology in the context of the UK. One thing we were discussing earlier is whether the nature of benefit cost analysis has to change when the decisions are not inframarginal, but in fact are the interventions being considered are so large that they would have major health effects on the entire economy. I'm thinking about something like AIDS treatment, but there are other examples. And those examples are likely to pertain to countries other than the UK, like Malawi, a country that's frequently come up today. So your handy list of the constants, or at least the parameters that we'd like to know, just the way you framed your analysis, those are all constant. You would have, obviously, you're saying that they would differ by context and so forth, but you're not allowing, for example, diminishing marginal utility, diminishing marginal value. And I'm wondering how badly you're going to lead us astray when we're dealing with major interventions which affect entire populations and economies.
Yeah, for sure, mate. And you know, in a sense, it was complicated enough. But you're absolutely right. The K's, the KH's, the health opportunity cost of healthcare expenditure, subscript T in each period, what I've represented here is the margin. So for things that are marginal with respect to total healthcare expenditure. But you're quite right, in low-income settings, we're often considering things that are profoundly non-marginal. And for that, we need to have some understanding or some kind of default, some thought about the fact that, you know what, if it's non-marginal, that pay is a hell of a lot lower. We're eating into an awful lot of stuff. If we're trying to find that non-marginal impact from existing commitments, we're eating into an awful lot of stuff that's really valuable. On the other hand, if we're thinking we're going to massively expand healthcare expenditure, the opportunity costs of that are more modest because of diminishing marginal returns. So yeah, we have to have some thought about the fact that these Ks depend on the scale of the delta Cs, the delta CHs. Now, what do we know about that? Again, and I'm sorry I keep going back to the UK, but it's kind of where, I guess, in a policy level, we've been most explicit. So, for example, UK Department of Health asked us to try and estimate non-marginal effects precisely for this reason, to look at the Hep C. We tried to do that with split sample design, and we did estimate those non-marginal effects. In the UK, they're appear to be relatively modest. It's basically about, I don't know, it's about 5% on the 770 million pound bill for the Hep C drug. So absolutely, you're quite right, and we have to keep those things in mind, and we have to marshal the evidence such as it is. I don't know if that answers your question, but again, you know, don't shoot the messenger. The world's complicated. We're just exposing that fact and asking people to consider these things when valuing the stream of expected effects of a project and thinking about considerations in a deliberative decision-making process. I guess